All right, today we'll be talking about calcium balance and osteoporosis. So why do we want to know about calcium balance and what is its relevance? Well, first of all, we need to know about the roles of calcium and what it does in the body. So calcium has very specific roles within our body, and they are quite varied and also very important to survival. First of all, calcium is responsible for neurotransmitter release. And as such, without it, we will have problems with neuron firing as well as other signal transduction pathways, as it is responsible, or the influx of calcium is responsible for triggering synaptic vesicles to release neurotransmitter. As well as we know action potentials are carried down certain fibers and muscles due to the depolarization caused by calcium influxes. Additionally, it is important for bone formation as it is one of the key components in bone. It is also responsible for insulin release in a very similar mechanism as our calcium in our presynaptic terminals, allowing for vesicles to bind to membranes and exocytosing insulin into the bloodstream in a very similar fashion, which will be discussed more in your diabetes lectures and as well as PSP slides. Additionally, it is important for enzyme activity as it is responsible for many enzymes being converted from it's a cofactor required for converting an enzyme from its non-active form to its active form, as well as being a key component in our coagulation pathway, being factor 4. And therefore, if calcium isn't regulated correctly in the body, we'll have problems in all these areas, leading to many systemic symptoms. So where is calcium stored in the body? Well, calcium is stored mostly or basically completely in the bones, with it being 99% of all calcium present in bones, specifically in higher concentration in our longer bones as well as our larger bones, as there's just more mass there. With 99% being present in the form of hydroxyapatite. The 1% that is remaining, however, is then them can be broken up into further categories of being ionized, protein bound, and complexes with anions. In terms of how calcium is excreted from the body, it is excreted both in the urine as well as in feces. If we actually look at how much calcium is introduced into our body through digestion, approximately 1,000 milligrams of calcium is introduced into the body every day. However, only 350 milligrams is absorbed daily. Therefore, there is quite a buffer there that can be tapped into if there is a deficiency in calcium, which we'll touch on later when we look at how it is controlled. In terms of calcium balance and its control, it is regulated by three key hormones, which is parathyroid hormone, vitamin D, and calcitonin. So first up, we have vitamin D. Vitamin D is a fat-soluble vitamin that is present in the diet, but can also be metabolized and manufactured in the skin. And this is why with patients, there are two choices for them. If they have chronically low vitamin D levels, we can either go with the pharmacological approach, which is supplying the deficient vitamin D by giving them vitamin D tablets, or we get them to increase their exposure to sunlight. And this is specifically true in patients who have sedentary office work lives, as they spend most of the day inside and away from the sun and therefore don't produce as much vitamin D. However, vitamin D by itself has no effect in the body. It is only activated once hydroxylation occurs, and just as the word sounds like, we're adding hydroxyl groups to the vitamin D to convert it into an active form. This occurs first in the liver, where we add one hydroxyl group, and then another time in the kidneys, forming our 2-hydroxyl vitamin D compound. This is modulated by PTH, which increases process occurring in the kidneys, therefore resulting in more active vitamin D. However, in itself also acts as a negative feedback system to decrease our parathyroid hormone. Vitamin D acts to increase both calcium and phosphate reabsorption in the kidneys, as well as increases calcium and phosphate absorption of the gut. It also increases the breakdown of bones and releases calcium. So by looking at the roles of activated vitamin D, we can tell that its purpose is to increase our serum calcium levels when there is a drop in them. So next we'll be talking about parathyroid hormone. However, before we get there, we'll be looking at where it's produced, and that is the parathyroid glands. These are located posterior to our thyroid, and as they are the site of parathyroid production, therefore its function is to regulate our calcium balance. In terms of histological staining, there are 2 types of cells present in the parathyroid glands, and they are the chief cells and our oxyphil cells. The oxyphil cells are the larger cells present in the area. However, their function is unknown. Whilst our chief cells are smaller compared to our oxyphil cells, however, they are the key cells of importance as they are the site of parathyroid hormone production. Like all endocrine glands, they are hypervascularized as they require to be able to access the bloodstream rapidly to release their hormones to have effect across the body in a rapid and effective manner. In terms of blood supply to the parathyroid glands, it is supplied by the superior inferior thyroid arteries and the superior middle inferior thyroid veins. A key thing to note is that as the parathyroid glands are part of or located posteriorly and very much embedded in our thyroid, in cases such as a thyroidectomy, these structures may be damaged or removed in the process of removing the thyroid. So what is parathyroid hormone and what does it do? Parathyroid hormone is an 84 amino acid protein hormone. It acts to increase serum calcium levels when low calcium levels are detected by our chief cells, which results in the secretion of parathyroid hormone. And it is inhibited, or the secretion of parathyroid hormone is inhibited in the presence of high calcium levels. How exactly does parathyroid hormone go about this? Well, it's nicely depicted in the schematic to our right. So, low serum calcium levels causes our chief cells in our parotid glands to release parathyroid hormone. This has 3 actions. 1, it stimulates the breakdown or the resorption of bone, causing hydroxyapatite to be broken down into calcium and phosphate, increasing blood serum calcium levels as well as phosphate levels. It also acts to increase the reabsorption of calcium from our kidneys as well as excretion of phosphate. Additionally, it acts to increase or upregulate the conversion of inactive vitamin D to activated vitamin D in our kidney. This activated vitamin D then goes on to increase bone reabsorptions as well as increase dietary absorption of calcium. As noted before, that 350 milligrams can be increased up to 1,000 milligrams of absorption daily. So now we know how the body responds to low calcium levels and its mechanisms to increase calcium levels back to normal. So what do we do when calcium levels are above normal? Well, this is where calcitonin comes into play. Calcitonin is another peptide hormone and is made by our parafollicular C cells of the thyroid. As the name suggests, it is para or next to or adjacent to our follicular cells, which we know are the ones that produce our T3 and T4. And they are these little cells that produce this peptide. And how does it act to decrease serum phosphate levels as well as calcium levels? Well, it does this by reversing what has occurred with the secretion of PTH. As such, it acts to decrease renal reabsorption, decreases bone reabsorption, and decreases gut adsorption of calcium. This is a slide that shows a summary of the effects of the hormones involved in regulating calcium and phosphate metabolism in our body. And as such, it showcases what parathyroid does in comparison to calcitonin as well as vitamin D, our three key hormones in the regulation of calcium balance. Next, we'll be looking at the conditions that arise when there is an imbalance in our calcium levels. First up is hypercalcemia, which is when there is an increased amount of calcium in our blood above normal. This is often markedly increased, I want to stress, and this is often due to hyperparathyroidism, hyperthyroidism, or paraneoplastic syndromes of tumors, which is when a tumor becomes an ectopic site of parathyroid hormone production, causing increased breakdown of bones. And as we know, when there's an increased breakdown of bones, we get an increased release of calcium and phosphate. A good way to be able to identify hypercalcemia in patients is by using the rhymes bones, stones, moans, groans, and psychiatric overtones, which cover the main components and the main signs and symptoms that a patient might present. The treatment of hypercalcemia is to resolve the underlying condition. Now we'll take a deeper dive into our bones and what happens there. So, our bones are in a constant state of remodeling, required to maintain healthy, strong bones, which is enabled by the constant formation and reabsorption of bone. This is because the matrix is constantly being broken down and replaced with new bone to create a more stable matrix to counteract the forces and stresses placed on it from the external as well as the internal world of the body. In terms of formation of new bone, the key cell responsible for the formation of new bone or the relayering of the bone matrix is our osteoblast. And these cells take calcium and phosphate from the blood and mineralize it into hydroxyapatite. A good way to remember this is that osteoblast is spelled with a B, and therefore B equals build, as opposed to its counterpart, our osteoclast, which act to reabsorb bone by breaking down hydroxyapatite and releasing calcium and phosphate into the bloodstream. A good way to remember this is that osteoclast is spelled with a C, and C is for cleaving hydroxyapatite or calcium and phosphate off of the bones, or cleaving bone, breaking them down. Specifically, there are key hormones that favor our osteoblast and those that favor our osteoclast. And these then act accordingly to regulate the production or the breakdown as well as the formation of new bone. And it is when we have an imbalance between these hormones that we have problems. And how exactly do they do this? We'll discuss in the next slide. So how exactly do these hormones act to increase or decrease bone reabsorption? Well, that is quite simply via RANKL ligand and osteoprotogen, which are local signaling molecules produced by our osteoblast. And it is the ratio of these signaling molecules that result in either increased bone reabsorption or decreased bone reabsorption. How exactly this happens is that RANKL, which is produced by our osteoblast, binds to RANK, which is a receptor found on our osteoclast, which increases the production and maturation of our osteoclast, therefore resulting in increased bone reabsorption. Osteoprotogen, on the other hand, is a signaling molecule produced also by our osteoblast. However, they are analogous with our RANK receptors found on our osteoclast and therefore bind to RANKL, preventing it from binding to RANK, thereby preventing increased osteoclast formation. Specifically, how it does this is because Osteoprotogen has a 500-fold increase in affinity to RANKL compared to RANK, and therefore binds preferentially to RANKL, therefore reducing RANKL's binding to RANK, and therefore reducing bone reabsorption. Our hormones, parathyroid hormone, vitamin D, cortisol, act to block the production of osteoprotogen and increase RANKL production by modulating intracellular processes, as opposed to what happens with estrogen, which acts in the opposite direction, as well as growth factor and the other hormones listed beforehand, which act to increase the production of osteoprotogen and decrease the production of RANKL. Now we'll look at osteoporosis. Osteoporosis is a condition caused by the imbalance between bone formation and resorption, which is therefore indicative of an imbalance between the hormones at play that we noted in the previous slides about those that control osteoclast formation, as well as those that increase osteoblast activity. Osteoporosis is a condition that is mostly asymptomatic until a trauma occurs, which causes a small trauma like a fall to become a major trauma, as it results in multiple bone fractures and fragmentation due to poor bone health and weakened structures of the bone matrix. Risk factors for osteoporosis are easily summarized in the word access, which is alcohol use, corticosteroid use, low calcium, low estrogen, smoking, and sedentary lifestyle. In terms of diagnostic criteria, that is done via DEXA scan or a dual energy X-ray. And it basically fires two different wavelengths of energy into your bones, with the low energy being absorbed by our medullary bone compared to the high energy being more absorbed by our trabecular bone, which is then subtracted from each other, giving us a score. This score is then plotted compared to the usual population, and then we can create a T-score, which is a patient score compared to that of the population. And if they fall 2.5 standard deviations below that of normal, we deem it as osteoporosis. Between -1 and -2.5 is known as osteopenia, which is the less severe version of osteoporosis. In terms of preventing osteoporosis from occurring, the key prevention strategies are modifying our risk factors and supplying the deficiencies that occur, which are low calcium levels, our vitamin D, and estrogen levels, especially in those of postmenopausal women when their estrogen levels rapidly drop off. In terms of treatment of osteoporosis, first of all, it's having the correct diagnosis. And osteoporosis should be a diagnosis of exclusion, where we identify and find other underlying conditions and or medications that may be causing the osteoporosis first, and then treat it accordingly for our weakened bones due to increased breakdown of our bones. And that could be hyperthyroidism, hypogonadism, which results in increased breakdown of our trabecular structures. In terms of drug treatment of osteoporosis, there are two key drugs, which are our anti-reabsorptive and drugs, which inhibit bone reabsorption, and our bone anabolic agents, which stimulate bone formation. As osteoporosis is a silent disease, patient tolerance to these medications is low, and there is no direct comparison between different treatment regimes. So the exact best gold standard approach to osteoporosis is very inconclusive, as it's both tedious and there's low compliance due to it being a silent disease and the drug regime being quite cumbersome and annoying to follow. Although there is treatment courses is very dependent on risk factors that the patient has, as some of these drugs act to exacerbate certain risk factors due to their adverse reactions and drug toxicity. The gold standard in most scenarios is the use of biphosphonates. Now, looking at our two types of drugs for osteoporosis treatment, They can then be broken down into a few specific drug classes, one being our estrogen replacement hormone therapy, and that is used in patients such post-menopausal women who have estrogen drops, and this can help in the short term. However, due to its increased risk of breast cancer and cardiovascular risk, it's not the best treatment option. To try and counteract this, we have created SERMs, which are our selective estrogen receptor modulators, which act more specifically and more targeted for osteoblasts to increase the production of OPG. However, it is not a perfect drug, and as such still results in cardiovascular risks, which then need to be weighed up whether the benefits of preventing a fracture is worth dying of a heart attack, and so on and so forth. Bisphosphonates are the key drug of choice and the one most usually prescribed, being the first line treatment, basically all practitioners, unless patients are allergic or that there is no effect by biphosphonates. Biphosphonates, they are pyrophosphate analogs. An example is aldronate, which is the often one that comes up in exam questions. And basically it inhibits the formation and activity of osteoclasts by binding to and integrating into the matrix of our bone, and they are toxic to osteoclasts, thereby killing them when they are activated and begin the reabsorption process. This medication is usually taken orally, but due to its poor oral bioavailability, there is a strict regime that needs to be followed, and it must be followed correctly, or you might jeopardize yourself, resulting side effects of esophagitis. Newer versions of this drug are IV medications such as zoledronic injections, which are once per year, which have better patient compliance and are often used when the patient is unable to follow the oral medication process, as a missing dosage will result in decreased bone density, which is the opposite of what we're trying to achieve. However, with both these drugs, there is also the increased chance of osteonecrosis of the jaw and atypical fractures, as although it decreases osteoclast activity in our long bones and prevents fractures in certain areas, other bone areas, specifically that of the jaw, require more remodeling to occur. And if we prevent osteoclast activity from occurring, it reduces the remodeling process and it's more likely to be damaged. And when damage occurs, if it can't be replaced and renewed and remodeled, we get necrosis of the bone in that area. And therefore, this is a negative side effect of these drugs. Musobab, as indicated by the MAB ending, is a anti-monoclonal antibody against RANKL, and it basically binds to RANKL, preventing its action, very similar to what OPG does. And basically it reduces the function of osteoclasts as such, and it's injected every 6 months. And basically the only indication of using it is when biphosphonates are unsuitable. However, as they are a monoclonal antibody and a new invention, they are very expensive and very costly for the patient. Next, we have the bone anabolic agents, which stimulate bone formation, which is human parathyroid hormone, which is lab-made parathyroid hormone that acts to stimulate the body in the same mechanism that parathyroid hormone does in the body. And you might be wondering, if that is the case, as we know, parathyroid hormone acts to increase bone breakdown, then why would we be trying to give it to a patient? However, this is in studies done, if we are able to give patients a low dose parathyroid hormone, it actually has an anabolic effect in the body by stimulating osteoblast development and activity, and therefore can be used in low dosage amounts to increase bone formation. However, its treatment is restricted to a total of 18 months, where after that, the patient is probably required to switch over to some other form of anti-reabsorptive agents to continue treatment if the osteoporosis persists. I think I missed this, but in terms with bisphosphonates, it's recommended that the drug is stopped after prolonged treatment, long-term treatment, that of 5 years in this case. And this is because after prolonged treatment, our biphosphonates are basically a compound that bind to our hydroxyapatite bone matrix and actually fuse and are able to stay inside our bone matrix for multiple years after cessation of drug is ceased, allowing for the body to maintain its anti-fracture properties without being continuously exposed to the toxic effects of biphosphonates, and therefore hopefully reduce the risk of osteonecrosis of the jaw as well as atypical fractures that may occur.